Hi students, it's Dr. Ways and welcome to your lecture on the pharynx and the larynx. We're going to start with the pharynx because that is the one that's most closely associated with the external world and anatomically sits superior to the larynx. So everything that's going to happen in the pharynx happens before it gets to the larynx. And there are three parts to this structure: the nasopharynx, the oropharynx, and the laryngopharynx. And you see these divisions right here. This would be the nasopharynx, which would be the part of the pharynx that's associated with the nasal cavity. So it comes after the choanae. Then the oropharynx here, which is associated with the oral cavity. And of course, here is the uvula right here, which swings backwards and cuts off the connection between the oropharynx and the nasopharynx, so that food coming in only goes one way, and that's down into the next part, which is the laryngopharynx. So the laryngopharynx is right here, and it is separated from the larynx by this epiglottis right here and continues on into the esophagus. The pharynx is approximately 12 centimeters long, and if we're looking at it in terms of where it is in relation to things we've already talked about, it goes from the base of the skull, all right, so right here where the sphenoid bone is, to the cricoid cartilage, and we talked about where that is in the neck, at about the level of C6. So if this is C1, 2, 3, 4, 5, C6 right here is where the whole thing would approximately come to an end. And then anything beyond C6 would be strictly esophagus. All right, its widest portion is right here at the base of the skull, and then as you notice, it narrows as it goes down. It's a collapsible tube as it moves into the oropharynx and the laryngopharynx. And it has openings to 7 different cavities. The 2 nasal cavities, remember that structure those structures we talked about in the nasal and oral cavity lecture, the choanae. 2 tympanic cavities, and so tympanic is going to refer to the tympanic membranes of the ear, and we'll talk about the openings to that. The oral cavity, and that's going to be right there, obviously. We'll do that in a different color. Oral cavity, the larynx, which is going to be right here, and the esophagus, which is going to be down here. On the inferior border of the sphenoid bone, within the mucosa of the the nasal cavity actually, we have the pharyngeal tonsils. All right, so pharyngeal tonsils are going to be in the back of the nasal cavity within the nasopharynx, and that's going to be a mass of lymphoid tissue. All right. They're also known as our adenoids. So when they take out tonsils and adenoids, these are the adenoids that they are referring to. This opening right here is the opening to the auditory tube, so the pharyngeal opening to the auditory tube. So now you actually see where it goes into the nasopharynx. We'll see where it comes from when we cover the ear. But for now, we'll just refer to it as a tube that's about 3.5 centimeters long, connects to the tympanic cavity of the middle ear, so the middle ear where the bones are. And the anteromedial 2/3 is made up of elastic cartilage, so that which is connected to the nasopharynx about 2/3 of the way is elastic cartilage, so that means it's highly stretchable. And then the posterior 1/3 is is made up of bone, so it's within the bony labyrinths of the middle ear. This pharyngotympanic tube is also known more commonly as the eustachian tube. There's a ridge surrounding the opening to the pharyngotympanic tube that's made of cartilage, and that's called the torus tubarius. That is then going to extend into the salpingopalatine fold associated with the soft palate, the salpingopharyngeal fold, which is right here associated with the lateral wall of the pharynx, and the torus levatorus which is right here. And that's between the other two folds. And these folds are really landmarks, not really any specific function, and they exist because there is a muscle that lies deep to each one that's forming those folds. So the muscular wall of the pharynx has indentations of the muscles that are deep to it. Posterior to the torus tubarius is the pharyngeal recess, so that would be this area right here. And that's going to contain some lymphoid tissue that, functions in surveilling the external environment and getting rid of the pathogens before they can get into the digestive or respiratory tracts. And then this area right here is going to be the pharyngeal isthmus, which is going to communicate the nasopharynx to the oropharynx. And then that's going to have anteriorly be bounded by the soft palate, and then the wall of the oropharynx posteriorly, or wall of the pharynx posteriorly, the transition zone. All right, so the pharynx is going to begin the nasopharynx is going to begin right here past the choanae, the posterior openings of the nasal cavities, and extend into this red line that you see surrounding. So all of that's going to be part of the nasopharynx. And here you see the openings of those pharyngeotympanic tubes, and notice that they are made of cartilage, and then they extend into the bone, and then up in this portion they will be bony. All right, so what we're seeing is the cartilaginous portion of it. All right, looking at our oropharynx, which is the next structure, using our uvula, which is in the oral cavity, remember, as a marker, there are several landmarks that will demarcate where the oropharynx starts. And that begins with the palatoglossal arch. So this fold right here, that's the anterior border. And then we have this fold right here that is in the posterior border, and that's called the palatopharyngeal arch. So one associated with the tongue, the other associated with the pharynx. Between them, what you'll find is the palatine tonsil. On either side, the palatine tonsil. And those are, when we talk about tonsils in our mouth, those are what we're referring to. So it's a good idea to know where they are. And there's actually a rating system that you will learn in your physical exam lab that will tell you how big they are based on how much of the space they actually fill up relative to each other. And then what you see back here is all the posterior wall of the oropharynx. So you're literally looking at the back wall of what you would commonly refer to as the throat, but specifically it's the oropharynx. All right, so just to point out, we've been using this term salpingo when we talked about the folds within the nasopharynx that actually extend into the oropharynx. Salpingo means tube. All right, so that term, for medical terminology, refers to a tube. So anytime you see salpingo, think tube. You might hear this elsewhere too when it's referring to the fallopian tubes or uterine tubes. So make sure you know that term salpingo and be able to differentiate between tubes that are within the pharynx and tubes that are within the uterus. So what we see in this picture, here is the palatoglossal arch, and then here would be the palatopharyngeal arch right here, and then of course between them you have the palatine tonsils, and they're going to be on either side, so you're going to have a pair of them. And then this area right here would be referred to as the oropharyngeal isthmus, where the like it says, the oropharynx is continuous with the oral cavity. All right, one thing about the tonsillar bed, it is highly vascularized, so if it's damaged or during surgery or infected, it does have the propensity to bleed. Lastly, we have the laryngopharynx, and that's this area in purple right here. And notice that it ends at the inferior border of the oropharynx at the level at which the epiglottis is when it's in open position. So in the open position, the laryngeal pharynx is continuous with both the esophagus as well as the larynx. All right, so on the next couple slides, we're going to talk about specific structures associated with the laryngeal pharynx from a different view. All right, so here we're looking at a posterior view of the the laryngeal pharynx, and here is that epiglottis that we talked about. And so the laryngeal pharynx would occur from here down this way. All right, this would be the opening to the larynx, we'll mark it with L, and this would be the opening to the esophagus right here. So the space in between is what we want to talk about right now. So if the larynx is anterior, then anything from the larynx back posteriorly is going to be considered the laryngeal pharynx to the laryngeal pharynx wall, the back wall. On the anterior side, you have these two little recesses right here called piriform fossa, or piriform recesses. So what happens is when food is being swallowed, this epiglottis closes off right here, and then food is diverted down either side where the piriform piriform recesses are located, and then we'll head down into the esophagus. Where the piriform recesses are located, just deep to them, you're going to have the internal laryngeal nerve as well as the superior laryngeal artery. So if those recesses are damaged by, let's say, something sharp that you swallowed with food or some sort of infection, you have the potential to damage both a nerve and a major artery that supplies the larynx. All right, from a superior view, again, just to point out, here is the epiglottis, and let's assume that that is going to be closed, closing off the larynx, and food will be diverted here and here to either side where you see the piriform fossa, and then they'll drain into the esophagus. All right, and then here is showing you the palatal glossal arch and the palatopharyngeal arch right here with the palatine tonsils in between. And I know this says palatopharyngeal arch, but that is actually the palatoglossal arch. And I just double checked this in a newer edition of this book, and they have actually corrected that. So palatoglossal arch, palatopharyngeal. All right, the pharyngeal wall consists of several layers going from most superficial to deep. We have the mucous membranes, which we are familiar with, and that's going to line the entire external portion of the pharynx, and that's going to be continuous with the nasal and oral cavities, larynx, as well as the auditory tube. So all of that mucous membrane is continuous. Underneath it, we're going to find a fibrous layer. We're going to have fibrous connective tissue that's going to hold things together. And then, of course, we're going to have a muscular layer with some muscles that are involved in swallowing as well as vocalizing. And then we'll have a fascial layer that is another layer of connecting everything together. All right, so next we'll move into the larynx, and I apologize if this picture got mixed up. All of the information is still there, but the picture just looks a little bit weird. So, Larynx Overview, the larynx, otherwise known as our voice box, is mostly cartilaginous, all right? And we talked about the different cartilages that are in this area, but now we're going to talk about them more functionally. And it's going to begin at the superior end of the trachea, so it's not the beginning of the trachea. The trachea actually begins right here with the first cartilage, but it's going to be everything that is superior to that, but inferior to the hyoid bone. All right. The functions of the larynx, one acts as a valve to guard the air passages during swallowing of food, and that's going to be primarily the function of the epiglottis. It's going to help maintain an open air passage. Okay, the reason why we have all these cartilaginous structures is because they're rigid and they're going to hold the airway open. We don't want the airways to be a collapsible tube like the esophagus. We want them open because air is going to be important to move in and out constantly. And it also aids in functions in vocalization, and we'll talk about the vocal cords and how they work as we move on. All right, and we'll begin with the thyroid cartilage, and we've already talked about the thyroid cartilage, and it's very easy to find in yourself. Can anybody think of another name for the thyroid cartilage? That's right, your Adam's apple. It's also known as your Adam's apple, and it's going to be the largest of the cartilages within the larynx. All right, and of course there's going to be two sides, left and right, and the wall of it is going to be called the lamina. So you have a left and right lamina. Where those meet in the middle and form a notch, that's going to be called the superior thyroid notch, and the fold at the anterior end is going to be the laryngeal prominence. So that's what you will actually feel at the anterior. That's what you will feel actually when you feel it along your neck, is that superior thyroid notch as well as the laryngeal prominence. On the posterior side, we have this superior horn pointing upwards. That's why it's called superior, and the inferior horn, which is smaller, pointing downward. And dividing or separating the lamina from the horns is a structure called the oblique line. Okay, the superior horns will attach to the hyoid bone with these ligaments. The inferior horns are going to articulate with the cricoid cartilage below, which looks like the beginning of the trachea, but it's one cartilage ring above where the trachea begins. And the importance of mentioning this oblique line is that is where the strap muscles of the neck will attach. Remember those strap muscles we talked about? The sternothyroid, for example. That's where those will attach. All right, just inferior to the thyroid cartilage is the cricoid cartilage. And the cricoid cartilage, when you strip away the superior thyroid cartilage, to me looks like a ring, where this would be the back of the ring and this would be the front of the ring, where your gem would be located on the anterior surface. That's just how I look at it. Let me erase some of this. So first of all, we see that the cricoid cartilage is not the beginning of the trachea, because we define the trachea as having these C-shaped rings and soft tissue in between, so that when food is going down the esophagus, this has room for being pushed inward and doesn't affect the cartilage. So the cricoid cartilage is actually a complete ring, all right? So that's what differentiates it from the trachea. The posterior part is the larger part, okay? So if we turn that around and look at it, there is a central ridge running along the middle, and on either side of that are depressions. If we look on the anterior side of the posterior part, that's referred to as a lamina. So lamina refers to a sheet. So we've seen lamina in a lot of different structures throughout this class. So lamina just means a sheet-like structure. So this would be where the lamina is. All right, and the part that extends anteriorly, where the back of the ring, if you will, would be called the arch. For identification purposes, this lies at the level of about cervical vertebrae 6. And the ligament that runs between the cricoid cartilage and the first ring of the trachea is referred to as the cricotracheal ligament. And that's the only one that we're going to learn that has with a specific name to it. But that also tells you, and we didn't discuss this, that the soft tissue between each one of the tracheal cartilage rings is a ligament. So we know certain things about ligaments and what kind of tissue that makes them up. All right, we have here that what the upper border connects to, but I'm not going to talk about that until we actually talk about those cartilages individually. So the next set of cartilages are much smaller, as you can see, and they have this triangular shaped appearance, and they are known as the arytenoid cartilage. So these are what we consider paired cartilages, and notice that they are on the superior border of the lamina of the cricoid cartilage. All right, and if you look at the previous slide, there were articulation spots for that. So here is where those articulation spots are going to connect with the arytenoid cartilage. All right, your book, Gray's Anatomy for Students, calls them pyramidal shaped, triangular shaped. The apex, of course, would be above, and the base would be down below. And they have two important processes to them. Notice, like when we did with the bones, we pointed out how certain bones were oriented, and with this cartilage it's no different. So if you see the rounded edge, that's going to be more oriented posteriorly, and the pointed end is going to be oriented more anteriorly. All right, the anterior end is referred to as the vocal process, and we'll see how that works when we get to actually how vocalizations are made. And the back is referred to as the muscular process. So the vocal process is going to be attached to the vocal cords, whereas the muscular process is going to be attached to muscles. So when muscles contract, they're going to move this end, which is going to put tension on the anterior end. All right, next is the epiglottis, and notice that the epiglottis is this leaf-shaped structure, and it is made out of cartilage, and of course it's going to have mucous membrane that's covering it, and it's attached to the anterior end of the thyroid cartilage about 2/3 of the way up by this thyroid epiglottic ligament. So there's a really small ligament attached to the thyroid cartilage, and its job then is to fold downwards during the process of swallowing so that the opening to the airway is closed off and food is directed down into those pharyngeal recesses and then down into the esophagus instead of into the airway. And so the hole right here into the airway is called the glottis. So the epiglottis would sit on top of the glottis, which is where its name comes from. The last two cartilage pairs are called the cuneiform cartilages and the corniculate cartilages. All right, the corniculate cartilages sit on the apex of the arytenoid cartilages, and again, they're a paired structure. And the cuneiform cartilages here look like they're just suspended in midair, but here you can see that they are embedded within a fold of mucous membrane between the epiglottis and the arytenoid cartilages. So this is a better view than the previous picture of where those smaller cartilages sit. So here are your cuneiform cartilages, and here is the aryepiglottic folds that they are embedded within. And notice that these go along the lateral parts of the epiglottis. So when it closes, the glottis flaps over the top, these folds are going to fold down with it. Attached to the corniculate cartilages would be this vestibular ligament right here on either side, and those two ligaments together are going to form what we call the false vocal cords. And then here at the anterior end of the arytenoid cartilage, going to the posterior border of the thyroid cartilage, are going to be our vocal ligaments, and those are going to be our true vocal cords. So the true vocal cords being attached to your arytenoid cartilage, remember you have one end that's attached to the vocal cords and the other end that's attached to muscles, and when those muscles contract, they allow the arytenoid cartilage to pivot, and when it pivots, it's going to put more tension on the vocal cords, which will allow you to change the frequency of the vocalizations that you're making. And so less tension would result in more low vocal tones, and high tension would result in more high vocal tones. All right, and those kind of changes are the result of, and I know you guys are probably laughing now, of changing the position of these arytenoid cartilages and thus putting more or less tension on those vocal cords. We didn't talk about this in one of the previous slides, but the epiglottis is also attached to the hyoid bone. And so if you move the hyoid bone, that's also going to move the epiglottis. And so muscles of the larynx are those that are going to be involved in, are divided into a couple categories. One are your extrinsic muscles, and the extrinsic muscles of the larynx are divided into the elevators and the depressors. So you see them outlined here, and I color-coded them on the pictures here, and those are going to be involved in opening and closing of the epiglottis. Intrinsic muscles of the larynx then are going to be responsible for your vocalization functions. So we already went over the extrinsic muscles when we covered the muscles of the neck. So now we'll go into the details of the intrinsic muscles of the larynx, beginning with the cricothyroid. And the name tells you exactly where it's located, between the cricoid cartilage and the thyroid cartilage. And its job is to adduct the vocal cords. So they're going to pull the vocal cords inward. All right, and the innervation of that is a superior laryngeal nerve, which is part of cranial nerve 10, specifically the external branch. So what this muscle does is it actually tilts the thyroid cartilage forward a bit and puts tension on the vocal cords. All right, the next muscle is the posterior cricoarytenoid cartilage. Cricoarytenoid muscle. Its origin is going to be the posterior surface of the lamina of the cricoid cartilage. So that will be back here. And its insertion is going to be the muscular process, so the back of the arytenoid cartilage. So when this muscle contracts, it's going to pull on the arytenoid cartilage and cause the abduction of the vocal cords. So it's going to separate the vocal cords from each other and open up the airway. And often this is called the safety muscle because it's responsible for maintaining airway patency during breathing. Its innervation is the recurrent laryngeal nerve. The lateral cricoarytenoid cartilage is this small muscle right here that is going to be on the arch of the cricoid cartilage, and the insertion is going to be the muscular processes of the arytenoid cartilage, and so it's going to pull not backwards on these but forward, and that is going to result in the adduction or closure of the vocal cords. And this one is also innervated by the recurrent laryngeal nerve. So just to point this out, here would be where the posterior would be attached to, and if you're pulling the arytenoid cartilage this way, that's going to pull the anterior end this way and open up the airway. But the other one is going to be attached here, and when it pulls, it's going to pull the posterior end this way, which is going to push the anterior end this way and close the vocal cords, or close the airway rather. The aryepiglottic muscle is attached to the from the arytenoid processes in the back to the epiglottis, and it's going to be work with other muscles to act as a sphincter to close the larynx when we swallow or when we cough. The thyroid arytenoid muscles here, going from the thyroid cartilage to the posterior surface of the arytenoid cartilage. They are going to be involved in adducting the vocal cords, because if we pull the posterior part this way, the vocal cords are going to go this way. The anterior part's going to move interiorly, so adduct the vocal cords. Again, recurrent laryngeal nerve is the innervation. The vocalis muscle is directly underneath the vocal ligaments, and its responsibility is to adduct the vocal cords, again supplied by the recurrent laryngeal nerve. So you notice the theme here: the recurrent laryngeal nerve is responsible for many of the muscles of the intrinsic muscles of the larynx. All right, so to break down the laryngeal nerves, here we have the vagus nerve coming here, and all the laryngeal nerves are going to be associated with the vagus nerve, left and right. So at the very top, above, branches off above the hyoid bone, we see the superior laryngeal nerve. And the superior laryngeal nerve has two branches. The external branch is going to innervate the cricothyroid muscle. So that would be this branch right here. And then the internal branch is going to pierce through the thyrohyoid membrane and innervate the mucous membranes of the larynx, supplying sensory innervation. The recurrent laryngeal nerves, if you follow the vagus nerve down, there's going to be a point where it branches off and then heads back up towards the larynx. So that's going to happen on the left side there, and then it's going to happen on the right side as well, although much farther superior than on the left side. And they're going to supply, as we saw, much of the innervation to the intrinsic muscles of the larynx, but they're also going to supply some more sensory innervation to the mucous membranes below the vocal cords, as opposed to the superior laryngeal nerve, which supplied it above the vocal cords. The blood supply to the larynx comes from two primary vessels: the superior laryngeal artery, and here's the superior laryngeal artery right here, which you see is a branch of the external carotid artery, and the inferior laryngeal artery, which is right here, and you see that's a branch coming off of the subclavian artery and the thyrocervical trunk. All right, looking at a posterior view with a coronal section of the larynx, we see that the laryngeal cavity is divided into three compartments. The first compartment is the vestibule, all right, and that's the part that contains the epiglottis right here, above the level of the vestibular ligaments. And remember, those vestibular ligaments were considered our false vocal cords that were above the true vocal cords. All right, so we refer to them as the vestibular vocal cords or the false vocal cords. The second compartment is the ventricle. All right, the ventricle, and you see the ventricle on either side, and those are folds that are between the vestibular cartilage and the vocal ligaments, vestibular ligaments and vocal ligaments. So they're the folds between them. And the function of these folds is they're between a lot of muscles, and they contain a lot of mucosal glands. And so they will secrete mucus, and when those muscles contract, the mucus will be squeezed into the area where the vocal cords are to maintain moisture of the vocal cords. And lastly, we have the infraglottic cavity, which is this space down here. So it's, remember, the glottis is the hole between the ventricular vocal folds, the true vocal cords. And so this infraglottic space would be the space below the hole, below the glottis, between the ventricular folds and the inferior border of the cricoid cartilage. And then everything after that would be strictly trachea. All right, so a little bit more about the vestibule, or actually each one of these compartments. The vestibule extends from the inlet here down to the vestibular folds, which are located right here. So this entire space right here. Anterior is going to be, of course, the epiglottis, and when the epiglottis closes, it's going to close off this area, and food is going to pass over it, down into those pharyngeal recesses that we talked about with the pharynx, and then go into the esophagus and not get into the airway. So it's going to protect the respiratory passages against the what we call invasion of food and foreign bodies. All right, the vestibular folds then here, we'll do them in red. The vestibular folds here then would extend from the thyroid cartilage to the front of the arytenoid cartilage. So it's going to go from a thyroid cartilage to the anterior border of the actually to the front of the arytenoid cartilages, not to where the true vocal cords are attached. And these are not involved in producing sound. They're not involved in producing vocalizations. So they, even though they look like vocal cords, they are not our true vocal cords, and that's why we refer to them as false vocal cords. Okay, looking from a superior view, here we see the vestibular folds right here on the lateral portion of, lateral to the true vocal cords right here. Here we see the epiglottis, as well as the tubercles formed by the two smaller cartilages of the larynx. So when this epiglottis closes, it's going to form a tight seal with this rima glottitis back here and close off this entire area. And so with a real picture taken from a laryngoscope, you'd see the false vocal cords right here, and you can see they actually look just like borders of mucous membranes, whereas the true vocal cords actually have kind of a whitish appearance that you would expect ligaments to appear as. Okay, so as noted here, the space in between the false vocal cords, the vestibular folds, is referred to as the rima vestibuli. All right, and the same muscles that adduct the vocal cords also adduct the vestibular folds, and that's going to close that opening between the false vocal cords. And what that allows you to do is increase interthoracic pressure or intra-abdominal pressure when you're urinating, defecating, or giving birth. So when you're bearing down or trying to squeeze the last bit of defecation or urination out, or trying to push that baby out, it's this closing of the rima vestibuli that allows you to build up that pressure. So reminding you that the ventricles are this area between the vestibular folds and the ventricular folds, or the true vocal cords, the false vocal cords and the true vocal cords. And remember, we said the function of these is that they contain mucus glands, and when squeezed, they will secrete mucus into this area and lubricate the larynx so it doesn't get dried out, which is an important function. But it also allows free movement of the vocal cord. So if you have this fold here, you're going to have a lot more latitude for moving the vocal cords, especially in relation to the true vocal cords to the false vocal cords. Okay, the true vocal cords, or the ventricular vocal cords, are these ligaments here, and you can see them in this laryngoscope picture right here that actually look like ligaments. They have a whitish appearance to them. And the space between them is called the rima glottitis, as opposed to the rim of vestibuli that we saw with the vestibular folds. And so that's going to be the narrowest part of the laryngeal cavity. All right, and when air gets pushed out of the trachea across these vocal cords, they're going to vibrate, and it's the vibration that is going to produce the voice. That's going to result in voice production. Okay, and we've already talked about when you put more tension on the vocal cords, they'll vibrate at a much higher frequency and produce a higher pitch. Whereas if you put less tension on the vocal cords, they're going to vibrate at a lower frequency and produce a lower pitch. So another look at the vestibule that we forgot to mention is that there is this structure called the valleculae, and that is composed of a median glossoepiglottic fold, so coming from the tongue to the epiglottis, as well as two lateral glossoepiglottic folds that will form these epiglottic vallecula, or valleculae, plural. And what those valleculae do is they collect saliva from the posterior tongue and actually will inhibit the swallowing reflex as a result. Why it inhibits the swallowing reflex has to do with the timing of the bolus of food entering into the area and the closing off of the epiglottis, so that swallowing can occur, that we're not going to get into in this class. Clinical significance of the valleculae are that they serve as landmarks for intubation, so that you know where to put certain parts of the intubation kit to keep the epiglottis open, so you can maintain the open status of the glottis. In Canvas, I will post this link right here that will take you to a video showing you how the vocal cords work. But for here, basically what this is showing you is the pay attention to the true vocal cords right here. During quiet respiration, this is what your vocal cords would look like. So when you're sitting there just breathing in and out, of course your airway is going to be open. There's not going to be a whole lot of tension on the vocal cords. During forced inspiration, notice that the vocal cords are widened a little bit, so there is a much bigger glottis opening because you're taking in a deep breath. Therefore, you're going to want to open the airway a little bit more. When you are speaking, notice that the vocal cords are in a closed position, and the muscles that we talked about earlier are going to put more or less tension on the vocal cords depending on what kind of sound you're going to be making sound you want to be making. When we force our vocal cords and our vestibular folds to close, this is what we see right here. So we don't see the vocal cords anymore because the vestibular folds are also closed too, and this is that bearing down position when we during defecation or urination or birth. This is what it would look like. So both your vestibular folds and your vocal cords are closed, adducted, and that's what this would look like. And then during swallowing, what you see is not only the vestibular folds closed, but now you see the epiglottis coming and closing off this area, and then food is going to be the bolus of food is going to be directed towards either side and forced down into the esophagus on the posterior side of the larynx, down the laryngopharynx and into the esophagus.